Mr. Shepherd, I've got some questions about the changes to Medicare and the health system. So let me begin with the statement that I think you made yesterday, where you stated that on average people saw a GP 11 times a year, and you said, I think in your words, Australians just aren't that crook. Mm-hmm. On what evidence are you making that statement?
Well, look, that average is the average, and
yes,
we've got that. So that seems to me to be excessive in any layman's
sure.
look at the thing.
I'm asking you for the evidence for the statement, I suppose, just to get to the crux of the question.
Now, the question is for us, and that was trying to be a little bit light-hearted at a time when things were getting tense, but the question for us is this: our health budget is huge. It's growing exponentially. It will eat up a lot of the budget of the Commonwealth and the states in the next 10 to 20 years, 10 to 30 years, and therefore it will become unaffordable. So how we looked at it was, well, how can we we've got a good health system, how can we retain the basic system and protect those that really can't protect themselves? How can we ensure that, you know, a family which suddenly has a chronic illness hit them not be forced to sell the family home to survive or any of that sort of thing? We don't want to go down the US route, but rein in this ever-burgeoning cost of health. And we tried with the balanced program to do that. Now, we did make one tough recommendation, which was those that can afford to look after themselves medically should look after themselves medically. So in terms of, you know, sort of middle-class welfare, we've said, you know, why shouldn't people who can afford it take out private health cover, which will in fact cover all of their medical expenses, while ensuring that those chronically ill, less advantaged families and what have you continue to be protected under the Medicare system.
So, Mr. Shepherd, I'm aware of the rationale, and I think it's articulated in the report. The premise, though, is that there is over-servicing in the system, and that the intent is to reduce the number of people going to see a doctor. I want to know on what evidence you made that judgment. What was the expert evidence? You acknowledge you're a layperson. What advice did you take to come to that conclusion?
Well, look, we got submissions from from the departments, and we got submissions from, you know, interest groups and what have you. But the evidence that we relied on that was basically just the ever-increasing
Yes, no, I recognise that. I don't, just in the interest of time, because I understand the general frame and I understand the pressures, and I agree there are some challenges there. But the basis on which that recommendation is made is that there is over-servicing in the system, and I just want you to point to any of the submissions that highlighted that there's over-servicing in the system.
I think one of the things is if the average is 11 for every man, woman and child in Australia, that would seem to us to be a very high level.
On what basis are you making that judgment?
Because
as a layperson, you say it seems, but what's the expert advice that you've relied on to make that judgment?
The expert advice that we've relied on to make that judgment is that whenever something is provided for free, the risk of overuse is increased significantly.
We're talking about a specific example, not some ideological framework about, you know, free riders and so on. I accept all of that. What is the specific advice that you received through your submissions that indicated that there were too many visits to general practice and that we needed to reduce the number of visits?
I'll have to come back to you on that.
Do you have any specific advice? Mr. Crone, do you have advice through the submissions that indicate that there is over-servicing in the system and that it needs to be reduced?
The specific issue of over-servicing, I think, is in some ways it may be a judgment call.
Yes, I know it's a judgment call, but it's not a judgment that lay people should be making without advice from experts, and I'm asking for the advice.
Okay, can we come back to you on that one? Because I do recall advice from the department on this specific issue, because this was a very sensitive area for us.
So you believe that there's advice from the department that indicates that 11 visits to a general practice is too high and it needs to be reduced?
No, there's advice. We have received advice that there is a high risk of over-servicing. Now, the second issue...
Not a risk of over-servicing, is there over-servicing in the system?
Well, there is a high risk. Now, the second reason for the co-payment is not so much for the over-servicing, which I think is an issue, a potential issue perhaps, but the co-payment is directed so that we reduce the cost to the taxpayer of providing medical services. So the primary reason for the co-payment is not the risk of is not the over-servicing.
Yeah.
The primary reason for the co-payment is for people to pay something themselves.
When asked to respond to that, you said Australians just aren't that crook.
I
want to know the basis on which you're making that statement. And you haven't provided any at the moment. And I would have thought that given the nature of this recommendation, you'd have some very clear advice through your submissions that would indicate that Australians have a much lower burden of disease than is reflected in visiting patterns to general practice. And as yet, I'm yet to hear you articulate that.
Hold on. Okay, let's reboot. The primary reason for recommending the co-payments was to share the burden with the consumer so that our health costs come under some form of control.
Well, perhaps we'll get to that in a moment.
Yeah.
Are you aware that people visit a GP when they're perfectly healthy? I've got 2 young kids. I take them to a doctor to get vaccinated. Are you aware of that? That sometimes it's not actually
Certainly,
disease.
and that's one of the reasons. That's one of the reasons.
I'll just finish the question, then I'm more than happy for you to respond. People visit a GP not just simply because they're crook. They visit a GP because they want their children to get vaccinated. They may be involved in a screening program. They may need to have a breast cancer screening, for example, or screening for colorectal cancer. They visit a GP when they're well, but they have a chronic disease like diabetes or heart disease, and to have their blood pressure controlled and to have their glucose controlled. So I'm just not sure that you're aware that visits to general practice aren't necessarily about treating disease, but it's also preventative.
I agree. We've recommended there also, though, that greater use, licensing or enabling pharmacists and registered nurses to provide some of those simple procedures under supervision and under restrictions and controls. That has been used in other jurisdictions. I believe it has worked, and it has certainly cut the cost of medical services. So things like vaccination,
yes, expanded scope of practice.
Expanded
yes.
scope. I mean, yes. You know, if we take pharmacists,
sure,
for example.
I don't want to interrogate that. I'm very interested in interrogating the co-payment. In the interest of time, I'd just like to restrict the discussion around that. So, on the issue of co-payments, are you aware of the modelling that's been done by, for example, the South Australian Health Department that demonstrate there's an increased risk of people using emergency departments rather than general practice because of the co-payment?
Yes, and that's why we referred to that specifically.
And so you talk about a co-payment to be introduced in hospitals?
In emergency.
In emergency departments. And I think you refer to the fact that the triage system would be an opportunity to determine the level of co-payment. Is that correct?
Correct.
So people who are at a low priority would be charged a co-payment, people on a high priority would not?
Yes.
Can I put to you an example in practice?
Sure.
Somebody at home, sitting at home drinking a bottle of Grange, has a very rich meal.
Bad pun. Bad joke. Bad joke.
Has a very rich meal, develops chest pain, presents to hospital, and is classified as a high priority case because of the risk of a heart attack. Another person notices a lump on their leg, it's getting sorer, they wake up, it's particularly sore one day, they present to an emergency department. Under that system, the person who presents with chest pain will be categorised as someone of a high priority, someone with a lump on their leg, low priority. Turns out that the chest pain is indigestion. Turns out that the lump in the leg is a bone cancer. So under your model, what you're proposing is that somebody who presents with a legitimate health condition, like a cancer, should be charged the co-payment. Somebody who presents with indigestion to hospital shouldn't be charged a co-payment. How does that work?
Look, we haven't drilled into the detail of this, and
but you're recommending it.
No. Look,
you're recommending.
No, but you must.
Let me return earlier to your statement. Can I just say?
Sure.
Earlier you said these are all sensible recommendations that should be implemented in full. And yet this is a thought bubble.
No, can I just come back to this? We haven't had the advantage of working through each of these recommendations with the relevant department.
So why recommend it?
But because I think in the implementation what you're saying is quite correct. So how do you implement a co-payment in the emergency ward of the hospital? Will have to be treated carefully.
But you can't do it. That's the point.
Yes, you can do it.
How do you do? Well, you haven't given me. I mean, what you've presented is an example of somebody who presents with a minor complaint who won't be charged a co-payment. Somebody who presents with a serious illness will be charged a co-payment. I mean, people have thought about this before, Mr. Shepherd, and it is very difficult. And what I'm surprised at is the lack of expert advice that you've used in coming to these recommendations, which will have a very serious impact on people across the country.
In all of our recommendations here, we've recommended that the Minister for Health have a close review. He's got a thorough review going on over the next 12 months. In the recommendation that follows that one, a pathway to reforming healthcare, the Minister should report to the Prime Minister in 12 months' time on progress and a preferred way forward. That's an overwhelming recommendation in an area where we recognise, despite the fact that we had submissions or what have you, we don't have the required technical expertise and we want to avoid unavoided consequences. Now, you will also agree that once somebody presents at hospital and goes into the emergency system, it is far more expensive than just going to the local doctor. And again, we looked at the New Zealand example where, in fact, they put in processes which encourage people to go to a doctor first rather than going to emergency. Once people go into the emergency system, the health cost grows exponentially, and you, as a practitioner, would agree with that. Yes. Now, there may be other ways of avoiding that situation and avoiding the crowding out of our emergency wards, which, you know, are an ongoing bugbear in Australia. And perhaps the Minister will find those. But we felt that it needed to be dealt with.
But on that point, I mean, you're recommending a 5% cut to hospital budgets by reducing the amount the Commonwealth pay to 45%.
Again, our view there is devolve power to the states in terms of running and building their hospitals. Don't micromanage it out of Canberra. And frankly, the efficiencies gained from that would probably cover the 5%. But
so you think the 5% reduction in the hospital budget, which amounts to billions of dollars, would be offset by the efficiencies gained if state governments ran hospitals
and ran them properly?
Okay, so this 5% reduction in Commonwealth funding would be completely offset by greater efficiencies. I don't know whether it would be completely offset, but there would be certainly incentives on the state to make sure they run and build their hospitals efficiently. Don't you think those incentives already exist through activity-based funding?
To a certain extent.
So what is this magical increase in efficiency that's going to be generated by the states running the hospital? I'll tell you the magical increase in the sort of efficiency we saw. We saw an example where the Commonwealth was co-funding the development of a hospital, and they had to move a car park 100 metres, a 28-car park 100 metres, and the funding stopped, and they had to do a complete submission to the Department of Health in Canberra to justify moving a car park 100 metres. That's the sort of waste that we're talking about. This is the sort of micromanagement that is, I think, adding considerably to the cost of providing health services. We don't disagree.
And the reporting, I mean, you know, each hospital does a report to the state. That report's not good enough for the Commonwealth. They've got to have their own series of reports. So they have another 100 people in admin, another 100 lines of code in their computer system to report to the Commonwealth. Cut that stuff. Cut that stuff. Trust the states, good or bad as they may be. Make them responsible. Make them get on with the job.
Mr. Shepherd, you and I are in wholehearted agreement on that issue, that there needs to be less duplication, and it is a big problem within the system. But it's a big leap to go from there to say a 5% reduction in the Commonwealth hospital budget as recommended by you.
Okay, and again, we've suggested that the Minister have a good look at that. He might say that's too harsh, I don't know.
Let me ask you a little bit about the co-payment issue. Now, all the evidence shows that you put in a co-payment. It's a very blunt instrument. Some people will be deterred from seeing a doctor and it will have no consequence, but it is particularly, it will disproportionately impact people on low incomes, and we know that the highest burden of disease is on people with low incomes, and they are much more likely to need a hospital service as a result of neglecting a complaint that could have been dealt with through the GP. How do you respond to that?
Well, we thought we've set for concessional card holders the co-payment at a fairly low level, and I guess we would also expect an implementation people with a chronic ailment would be again looked at separately. You could argue about the level of co-payment. Is $5 too much or not? Is that going to be a discouragement from going to the doctor? We didn't think so. It's about, it's a little bit more than a cup of coffee these days.
But the co-payment works on the basis of keeping people away from the doctor. That's the whole point of it.
Not really. The point of the co-payment is, the real point of the co-payment is people are sharing the cost of their health services with the government.
But whether the cost comes from the individual consumer or it comes through taxation, it's still a cost.
Sure.
So it can only work in terms of saving money.
It saves money to the Commonwealth budget.
Okay, but that's still money that's not sloshing around in the economy. I mean, how does reducing spending, government spending, but also imposing a cost on the individual consumer, that's just money that's not being put into the economy.
The Commonwealth has got to look at its budget as its own budget. If we can reduce the expenditure of the Commonwealth to a sustainable level, and this is what this whole report is about, yes, then the Commonwealth can continue to provide support to the disadvantaged and to do the things that the Commonwealth at its core should do.
Well, this is...
Now, if this means that the individual's got to pay more for the service themselves, so be it. The money is paid, it still goes to the doctor still gets the revenue, still gets the income, still pays taxes, still goes out and buys the new car. So, the money is still there in the economy, but the burden on the Commonwealth taxpayer is reduced.
This is where you and I will part company, and it is really on how it is most efficient to provide services, and whether government does it or whether the consumers do it. The aim for me is whether it's done efficiently, but that's perhaps a discussion for another time. The issue of co-payments in the PBS.